Thank you so much, Dr. Dhanesh, for joining us on a podcast at Dawdle. Extremely grateful that you took out time out of your busy schedule to share us insights around your experiences. We do understand that you have a prolific career, but just to give a context to our audience, sir, if you'd like to take us through your journey so far.
So I am Dr. Dhanesh, Bhargava is my full name. So I'm working as a consultant cardiac surgery in the Vedanta District Hospital, Gurgaon. And I'm also running my small setup in the Pandora district, and which is my sort of OPD come diagnostic clinic. So I'm seeing in my evening times and on the Sundays patients, so mainly the cardiac patients and sometimes the general patients. So this is my after finishing my work at the Vedanta, I start OPD here. So this is my whole curriculum. And I have pursued my MBBS from the PGI Institute. And after that, I have done my post-graduation and super specialization from the Lex Institute. And I also gained the multiple fellowships from the American College of Cardiology, Art Academy, India, also and some multiple annual programs, SAVI programs, and done a lot of things fully accomplished and performing with kind of surgeries and interventions. And I am well versed with all the literatures and upcoming innovations.
Sir, you have actively been a part of a lot of cardiology related societies. We will start with the first topic that we have, the use of AI inside imaging. Imaging में AI का काफी use अभी start हो गया है. Like many advanced imaging modalities now rely on AI for segmentation. Like you have the vessel delineation, plaque volume, etc. How mature do you think these models are in real world cardio or vascular imaging? And what can be the major pitfalls?
In the AI tools, mainly these are available in our high-end diagnostic 2D cardiography machines,
Yes.
and which we use in our routine practice. So mainly while calculating the gradients, so routinely these things they do is
Yes.
they need only one small number of images.
Yes.
Mainly you can take the two angles or two images, and they by using the algorithms and the use of AI, they
Yes.
generated the multiple images, and out of that they calculated the gradient, ejection fractions, PF pressures, all sort of data they calculate on itself. So also while we are calculating the gradient, we routinely measure the area which is covered, and we measure the gradient across the wall. So we do one by one. But once we do by use of AI, once we curve the one loop, automatically all the 5 or 7 loops which are available, they got all covered, and they calculate the average of output. So we got the average gradient while we measuring across the wall or any other things in the chart.
Yeah.
So these are the utility in the 2D cardiography machines.
Yes.
Also, there are CT scan, which are X-rays, MRI machines, all are also using these kind of things. So what they have been done is they have a pool of data,
Yes.
and so they have inserted it in the software.
Yes.
And if they anything which is deviated from the normal, they easily pick it. So they at least they can take this as abnormal. So definitely the role of doctor or radiologist definitely come in that. So to keep the scrutiny or anything whether it's correct or not.
Yes.
So also these are the things in the CT scan, MRI, X-rays. So all software are available with the AI equipped software are available for the reporting purpose. Also, my wife is also doing the EEG,
Yes.
EEG and ECG.
Yes.
So ECG also they provide the normal ECG to that. They detect is normal. Any
Yes.
irregular rhythm, they detect is irregular. So also they calculate automatically they calculate the PR interval or sort of interval, or also they put the minor abnormalities also. So by the use of sometimes the channelopathies or the left vein disease, which can be sometimes missed by the cardiologist or physicians, it can be sometimes can pick the wrong, which have to be cross verified by the cardiologist or the physician. So these are the things which are the upcoming in the ECG. So apart from that, you are asking about that the plaques which is present in the vessel.
Yes. Yeah.
So sometimes they calculate the plaques also, but by the from the CT angiography, they calculate the plaque burden or the percentage of the blockage. So, but angiographically, which we do, which is a dynamic thing, we provide give the dye and we visualize in the real time. So definitely the angiography is still standard, but definitely while performing a CT, FFR or other any like the ICUS or the OCT, So in these things also the AI is upcoming, and these are the software just in the initial phases, and we are using. So these things are very costly at this present time. So maybe in the future the cost will reduce, then multiple people can use this technology.
Sir, are there some risks involved, in all these kind of AI tools?
Yeah, definitely there are chance of the errors.
Yes, sir.
So AI can misdiagnose also.
Hmm.
So, but some most of the times it gives a differential diagnosis with the commonness diagnosis are at the top.
Yes, sir.
So recently I visited that AATS conferences of surgeons.
Huh.
So in the USA, mostly the literature and the data presented with only the 30% or 40% paper was only based on the AI itself,
Yes, sir.
use of the AI in the cardiac surgery or the cardiac science. So it's rapidly upcoming and like a thunderstorm. But
Yes.
definitely, we are getting more number of datas now. Though the upcoming time will future will tell whether it's a success or so. We are currently lacking data. Some data.
So also want to take your insights on these imaging biomarkers. Like you have these strains, CT derived fractional flow reserves. They are also gaining a lot of prominence. How do you see the validation and standardization of these metrics evolving?
As I told you, so definitely there is a multiple software available, and software all work on the database, a particular number of database, with the how
Hmm.
much the data is fed inside it.
Yes, sir.
So according to algorithm, they will diagnose and they detect the anomalies and all.
Hmm.
And also, while we are calculating the real time, sometimes we have to calculate the gradient across the wall,
Yes, sir.
pressure difference, or any sun. So at the time, the advantage, as I already told you, advantage is that you calculate the one waveform,
Yes.
automatically 5 or 10 waveforms which
Yes.
automatically calculate and can take out with the eyes. So this is the advantage of it, AI. So
Yes, sir.
also the number of images required for the more data is less.
Hmm.
Sometimes we require 2 or 3 images only, and then they calculate the whole all things, all the data, all the dimensions, it calculate itself. So,
Yes.
but these machines, the 2D machines, the 3D machine or 4D machines, they are very costly
Yes.
at this level. So they are roughly cost around 2 CR or 3 CR. So
Hmm.
very costly.
Sir, they are costly because they are being imported, like Indian
Yeah,
manufacturer.
so mostly are the GE machines
Yes, sir.
and the Philips machines. They're all coming with a high-end echocardiography machines are coming with the AI features, and
Yes.
they calculate the all the strains, dimensions, and all things with the use of AI. And they require definitely less effort is required to calculate the dimensions and gradients, and
Yes, sir.
because all the formulas are already fitted, and they
Right.
also the lot of data is already there, so they automatically change the angles, take the 2 3 images, and then all data is also on display.
Sir, one other topic is around combining these modalities, like you have MRIs, CT, PET, ultrasound, and combining these and extracting the radiomic features is basically very powerful, but a very complex thing. What challenges have you faced in integrating these multimodal imaging pipelines into clinical research workflows?
Yeah, definitely. Because in India, we are lacking behind in the research because we don't have a particular database or database center in our country. So for that, sometimes what we are doing is suppose you are purchasing the machine of suppose through GE or Philips,
Yes, sir.
or these companies itself has a pool of data. Suppose I'm at my
Yes.
center, I have GE machine.
Yes, sir.
So what they have done is they have linked my machine to the data pool, so the
Yes.
GE data pool.
Hmm.
So the all the dimensions or all the images I acquired in my T machines or the 2D whatever machines, they
Yes.
directly linked to that data center. So, company itself came with some dimensions or maybe in the research in the future
Right.
by calculating the dimensions or other things from the multiple centers and multiple machines which are installed at the multiple centers.
Yes, sir.
So itself, the company are doing a lot of research. So per se, the doctors or the scientists, they are doing less number of research, mostly because we are the country which has spent very less on the research purposes.
Yes.
So these things should be increased in the near future.
Yes.
So these are the challenges. So mainly we there are very less few people which are interested in doing the real research or some research work which is maybe earth breaking research or maybe no they're not they're doing research for them mainly thesis purposes.
Yes.
So the students are given the thesis and
Yes.
they do the research for their thesis, they complete their thesis, and no one is thinking out of the box to make the changes. So these things mainly they are doing mainly the IITians or
Yes, sir.
biophysicists, or they are doing
Yes, sir.
lots significant number of research in that. Mostly these are the genius people or the scholars. They go outside for the sake of money and for luxury. Maybe in the near future, France is traveling because of Trump. Maybe we can. Or,
But sir, one thing is there, Indian doctors are respected across the globe, irrespective of whichever country you go. Africa, US, Europe, everywhere. If you say Indian doctor, people trust them.
yes,
That kind of a brand that we have built, especially in the medical field.
yes, definitely. We Indians are the hard working,
Yes, sir.
and we are not that we will have a 150 IQ or 140 IQ or 160 IQ like
Yes.
the Israel people or the German people. No.
Yes.
So, but we are hard
We are
working
hard
and
work.
we have courage and we are dedicated people.
Yes, sir.
So that's why the other countries respect us and love us.
Yes.
These are the things.
So now talking about robotic system and robotic assisted vascular interventions, they are also emerging. But from a technical and safety perspective, where do you believe the current system falls short?
So there are two things. So one is the vascular, one is the cardiac part of it, and one is the general part.
Yes, sir.
So per se, in the general part, and then the orthopedics and the general surgery, that system is very useful.
Yes, sir.
So when it comes to the vascular part and the cardiac part, so for the major vessel anastomosis, the
Yes.
system is quite useful. But when it's come to the coronaries arteries, the visible arteries are supplying the heart. And when we perform the bypass operations, this system is not that friendly. So because it can give the magnified vision, but definitely the it's somewhat falling because while making anastomosis, the time required is more, and also there are also risks to the patient. Also, sometimes if the catastrophe happen,
Yes.
so we can lose the patient at that time.
Hmm.
So because we have in that case we have to which is a process called docking.
Yes.
When we install this robot on the patient, it's called docking. To undock the robot from the patient, it requires lot of time. It may require 30 minutes or 40 minutes sometimes for the untrained people. Maybe the trained people can undock easily, but that time is the money or time is the life. So for the conversion time is very more in the cardiac patients. So I will prefer in the cardiac patients, we are using it for the other procedures like the mitral valve repairs, mitral valve replacement sometimes, or maybe for conduit harvesting, the conduit the lima harvesting or the lima harvesting. For that purpose, it's okay. But when it comes to the coronary anastomosis, I don't think it's very useful. Maybe because our Indian companies also there, one called SSC Mantra, and also the other countries are Intuitive, Da Vinci companies also there. They are coming with all advanced robots. They are and also performing they are claiming they are doing the coronary work, but the results are not better than the what we do by the MICS or by the open line. So there is also the study is biased because all the health industry is all industry driven. But maybe the cardiac it's not useful. For the general purposes, definitely yes.
Sir, also there is a growing interest in these real-time analytics during surgery, like to give the doctors an indication of what is basically happening. So how feasible is it to integrate all these predictive models which give you insights into the environment where you are basically taking care of the patients, accounting for noise, patient variability and all that?
We are using these models for mainly for the diagnostic, whether 2D topography of the T.
Yes,
But per se, during surgery, we are not using at our center also. So maybe in the other countries like the USA, Germany, maybe they are using
yes,
it. And sometimes these roles came while we are performing surgery for the cancers. So also because they give the indocyan green, some sort of dye, and
yes,
the base of the ultraviolet, yeah, the indocyan giving the dye, they detect the tissue, whether and the delineation, that marker delineation line, whether
yes.
this part we have to remove or this we have to this treat. So in those things also because there is sometimes the AI tools are also available where sometimes the requirement of dye is very less, and by the software in the preoperative assessment they detect by the CT softwares they detect the cancer status till that end, and we have to remove that much part. So this is all AI driven, and I have visited that WTS conference, and I saw these models which detect the cancers preoperatively and they assess it and they they detect the particular delineation line till that line we have to remove
Yes, sir.
the tissue. So in those things it can be used, and this is being used in the other surgeries, not only the cardiac surgery, other surgery like the general surgeries, by removing the hepatocellular carcinoma, the renal cell carcinoma, or the GI cancers, and by the mid-thyroid cancer. So they are things that are using.
Sir, also there is a great use of these 3D models or VR, kind of specific patient specific simulations are becoming very common. So in
Yeah.
your domain, what simulation fidelity do you think is required for meaningful planning of surgery?
Yeah, so definitely these models, because at a particular time I was also interested in 3D printing, and I want
Yes.
to purchase a 3D printing machine for my patients also and for the research
Yes.
purposes. So definitely this has a role in the complex congenital anomalies, which when the anomalies were that complex, we have to preoperative early detect the anomaly, and we have to preoperatively make a plan of the surgery, and
Hmm.
it is very useful tool for the surgeons while
Yes.
performing surgery, and they feel less challenged comparatively if they came with a particular plan in the preoperative period. These 3D printing these softwares or replicas, they are
Yes.
quite useful in the while performing the complex congenital anomalies, not in a simple setting. Also, these are also for the educational purposes, also while teaching the students
Oh.
and while performing the seminars or any dissection halls, the anatomy, performing the applied anatomy, how much part have to cut. So for these things, educational purposes, is very quite useful.
Right, sir. Now, sir, we'll come to this post-operative monitoring and mobile health section, where there are a lot of variables and continuous hemodynamic monitoring which is being done. So post-operative patients with cardiac or vascular repair benefit from continuous monitoring, but you see a lot of sensor drift, signal knowledge, and artifact handling are real challenges. So what vital parameters do you think are reliably measured by these variables in vascular patients?
So mainly I can talk about the cardiac patients,
Yes, sir.
not only the vascular patients. There is real time cardiac output monitoring, which is called continuous cardiac output monitoring.
Yes, sir.
So this and also there is one thing called near infrared red spectroscopy or NIRS.
Yes, sir.
So these two things we use in our cardiac patients. So while performing the ARC surgeries, NIRS use is must. And also that continuous cardiac monitoring we use in the patients who are having the ejection fraction less than 25% or 20%, in which the continuous cardiac monitoring is required.
Yes, sir.
Yeah. Intermittently, cardiac monitoring can be done by the Swan Gang catheter, which is you can insert in routinely for patients. If the patient's condition is quite sick, which require the cardiac output monitoring in the real time and in the each and every second or few seconds.
Yes,
So
sir.
in that case, the role of the continuous cardiac output monitor is key. So I think these things and these models are very good predicting the continuous cardiac output in these patients. Also, the pulmonary artery pressures in the real time,
Hmm.
and also the volume or which is the filling pressures inside the heart. So these things can be converted in the real time by these monitors, which is available with us. And they are initially they are not using the AIs, but now they are coming the AI use.
Yes, right. And also, sir, there are a lot of engagement apps and digital interventions or gamified apps also coming up to make sure that the patient is adhering to what is required in the post operative mechanism. What are your views on all these kind of channels which are used?
Use of applications, there are lot of n number of applications are available with us. So they start from the preoperative assessment. Must have heard about the risk calculator scores.
Huh.
So there are multiple lot of applications available for the calculation of the cardiac risk calculators also available.
Yes, sir.
Instead of the Euro score calculators also,
Hmm.
and also the FTS calculator scores, WPS calculator, which for AQG scoring, is there already in the market for the preoperative assessment of the cardiac risk,
Hmm.
and also the predictive operative mortality in the post-operative period.
Yes.
So use of these calculators is for mainly for the risk calculations. If you want to perform the calculations by using the formulas, or you want to perform the intermittently, you want to calculate. Suppose you want to calculate the PVR
Hmm.
or SVR. If you are not using the Swan gains or the other things, so you want to perform these set of calculations, you can perform easily by the use of applications. So they are available with us. Also, maybe applications are also available for the help of the surgeons and the patients,
Yes.
educational purposes, and also there are number of applications that are available for the guidelines. Each
Hmm.
society and each their guidelines, like the AACTS and EACATS, and all the vascular and the cardiac societies have their own guidelines. So these are putting their guidelines on the applications so that can be beneficial for the surgeons and also for the patients. They can read and what is the great indication and when we have to wait, when we have to intervene. So they can read from that platform.
Yes, sir. So also, if you'd like to touch upon some of the ongoing collaborations that's happening between clinical teams and bioengineering labs, especially in cardiovascular surgery, because you see a lot of biomaterial and tissue scaffoldings are areas of interest.
Yeah, definitely they are doing a lot of number of research mainly, but our center, I don't know, we are lacking in that. We're not doing that. At particular moment of the time, I was coming out with a plan to make some changes or to come with a valve design change. So I want to collaborate with some maybe the physicist or some biomedical engineers in the IIT Delhi or IIT Mumbai.
Yes.
So but because of lack of the resources and lack of the willpower from my end, I dropped out that plan. So maybe in the future I will come with that. So, but definitely other centers and other institutes are doing collaboration
Yes.
from the biophysicists and the biomedical engineers for the development of the some raw products and also for the coming up with the new applications which can be useful for the patients and for the surgeons and also not only the surgeons for the or not and number of the doctors. Maybe they cardiologist, pathologist, radiologist, anything. Our center is not doing that much collaboration. We will come up with for the collaboration in the near future.
So also it has been seen is that a lot of high-tech tools exist, but the adoption is very slow in the clinical settings. So what are the key integration challenges that you see?
So mainly the cost constraint.
Yes, sir.
Each technology comes with a cost.
Yes, sir.
So if suppose if the institute uh, take some technology
Yes.
and he want to give the benefit to the patient of that technology, so he have to charge some amount from the patient also. So sometimes the patient is not ready to pay it. So these are the some limiting factors. Maybe for the research purposes we can use it, but to come in the it can be feasible in the either in the government sectors where the patient not have to charge much. You can charge take charge from the patients. But in the private sector, this is the most important thing. So, because suppose if you are doing a robotic surgery,
Yes, sir.
or any using the endoscope, particular sort of instruments, so they are coming with a cost to the private hospitals, and we can't give the benefit of these things free of cost to the patients. So we have to charge the patient.
Yes.
So
सर अब थोड़ा सा मतलब पब्लिक हेल्थ से रिलेटेड कुछ ओपिनियंस लेंगे if you talk about all the cardiac diseases, it seems that it has increased in India in the last 3-4 years. उसके पीछे what are the main reasons and how can people prevent those diseases from occurring?
So the first thing which has happened to us is COVID-19. So also the pollution is increasing day by day. Industrialization is increasing day by day.
Stress is also increasing day by day.
Stress is increasing day by day. Okay. So also the most of the patients, most of they have exposure to that COVID antigen already. So the patients or the people who have COVID infections. COVID is basically sort of multi-system inflammatory syndrome.
Yes, sir.
So maybe we have now we have saved from that COVID-19. We have got the all vaccinated. But sometimes what happened is even which the research should happen in that direction also.
Yes,
So
sir.
maybe that inflammation is also still ongoing maybe. So that could be a contributing factor for the increasing number of CJD in the patients. Also the pollution, gas, these things are all also there. Also the obesity and diabetes mellitus is also increasing in our country. So these are the risk factors. Also the patients who are having sort of a family history in their family. So they are not doing the screening at the particular age. They are advised to do screening at the below 35 years of age now.
Yes, sir.
Because the cutoff has changed. Now initially it's for 40 years, now it's 35 years. So the patients who are comes from the high risk groups. High risk groups are patients who are having a history of diabetes, or family members having diabetic, hypertension, or any genetic history in the mother and father and the grandfathers. So they are more prone for those risk factors. Also, some patients have the high level of homocysteine levels and apolipoprotein A level are very high in some patients. Though the reason is very less of the happening CAD, but it can happen. We have reported we have recently done a CABG in the I think maybe the 14 year, 15 years of your child.
Yes, sir.
Can you imagine? So it's happened in the so young of age. The reason was homocysteine, hyperhomocysteine. So the child was suffering from the hyperhomocystinemia and the increased level of apolipoprotein. So the vessels coronary artery disease were very badly diseased, and he underwent coronary artery bypass grafting at the 15 age. So we have reported this case. Also, all the patients which are uh, basically which have underwent any intervention, which have been diagnosed, they should take care of their blood pressure, manage their sugars well, they take care of all their lifestyle, and definitely take their medicines. These are the my advice from my end to the patient. Also, for the screening purposes, with patients who are coming, people who are coming from the higher risk groups, I need to told to diabetic, hypertensive, family history, hypertensive proteins, they should do regular health checkups below 35 years of age. They must have done their all body profiles, body counts at the 35 years of age. Also, the coronary calcium scoring is must nowadays.
Yes, sir.
For
Yes,
people
yes. So,
45
sir, would you
years
like
of
to touch
age,
upon this thing, sir? Coronary calcium score. Like,
score.
yes, sir.
So I am 35, 38 now currently.
Yes.
So I have done my scoring, and my score is 0. So because this is a very there is very negligible relations in this study. Also, there is no dyes given to the patient. Only patient will go in the CT scan machine, come out with CT scan. Hardly take 5 minutes.
Yes, sir.
So the score is 0 or less than 20 or less than 50 or less than 100. The risk of having CAD in next 5 years is very less.
Got it.
So
Yes.
sometimes the only disadvantage is miss the soft plaque. Soft plaque can mix in the 5% of the cases, but 95% of these cases it will give the definite diagnosis. The patient is not going to happen any CAD in the next 5 years. So they can repeat their scan in the next after the 5 years. If they found any calcium score is 100 or 200, they have to need to start the statins at the early stage of their life.
Yes, sir.
So this is the basically also ego TMT is they can do if they're any suffering from any basically valve problems or the congenital anomalies. This is very much nowadays TMT and eco and also the coronary calcium scoring. You can include in the card.
Sir, is there a direct linkage between high cholesterol levels and getting a heart attack?
Sometimes if the increasing level of cholesterol levels have direct correlations, definitely. Also, sometimes there is a lot number of the lipids which is there in our body, like the triglyceride, NDL, VLDL. If our triglyceride level is very high, it can be controlled. It's not that risky. But if the LDL level is very high, LDL, which is the bad cholesterol we call our language, this can create problem. LDL level is more than 100, then you are at the risk. You need to start a statin. It should be less than 100. And if your idle is less than 50.
Thank you so much, sir, for joining us. This was a very insightful session. We touched upon a lot of technical stuff and also your advices to the patients. We'll be in touch, sir, and thank you so much for joining us on this podcast.
Thank you. Thanks.
Thank you so much, sir.